Hi, my name is Amy Miller. I'm an assistant professor in medicine at Harvard Medical School. I'm going to be talking to you today about anti-arrhythmic drugs. I have no pertinent disclosures relevant to this talk. You'll be hearing a lot more about this in some of the more clinically oriented lectures, but before we delve into the pharmacology of these drugs, I think it's worth taking a moment just to talk a little bit about appropriate indications for antiarrhythmic therapy and an inappropriate indication. So some of the appropriate indications for antiarrhythmics include preventing secondary effects of arrhythmias. So the classic example here would be a tachycardia-induced cardiomyopathy. If you have a patient who's having atrial tachyarrhythmias that are causing a decrement in LV systolic function, then preventing those tachyarrhythmias is clearly beneficial to the patient. Probably the most common appropriate indication would be symptom control and symptom relief. The cautionary tale here is that not all patients who have arrhythmias have symptoms from their arrhythmias, and that's an important distinction. You can have a patient who has arrhythmias and has symptoms. The symptoms may not actually reflect the arrhythmia. And so it's always important to make sure that the symptoms that you're treating are actually related to the rhythm that you're trying to suppress, or otherwise you're still subjecting the patient to antiarrhythmics without a clear indication. And then, of course, reducing the risk of life-threatening arrhythmias and the related need for defibrillator shocks for those rhythms. So those would clearly be very reasonable indications for an antiarrhythmic. On the other hand, both providers and patients tend to focus on anticoagulation, and I want to go on this drug so that I don't need anticoagulation anymore. And antiarrhythmic therapy does not change your indication for anticoagulation, and trying to avoid anticoagulation is in no way, shape, or form an appropriate indication for an antiarrhythmic therapy. So just something to keep in mind. Having had that brief clinical interlude, we're going to jump into some things that may cause flashbacks to medical school days. So hopefully this action potential looks somewhat familiar. This is kind of your classic cardiac cell action potential. And just to remind you the phases of the action potential. So we have phase 0, which is this rapid depolarization, the rapid upstroke. Phase 1, which is this partial repolarization. The plateau phase, which is characteristic of cardiac cells. Phase 3, where we're repolarizing. And then phase 4, where you're slowly depolarizing. That's the pacemaker potential, which is the kind of autorhythmicity that you see in cardiac cells. The refractory period extends from phase 1 through phase 3. So this entire duration would be your refractory period. So if that is what the action potential looks like, what causes that? Well, if we look at the underlying currents, our phase 0, that rapid upstroke, is going to be caused by an inflow of sodium. Phase 1 is a balance of both the deactivation of that inward sodium current and the initiation of an outward potassium current that will continue basically throughout the remainder of the action potential. The phase 2 plateau you get because you have a slow inward calcium current that's balancing out that potassium outflow. And then in phase 3, you inactivate that calcium current. You just have the unopposed potassium, and that causes you to repolarize. In phase 4, the potassium outflow is going to slow, and you get a slow sodium inflow that causes that gradual depolarization. Now, if we think about the drugs that we use for arrhythmias, the most commonly used classification for these drugs is the von Williams classification of antiarrhythmics, and it breaks them down essentially into where they act in the action potential. So our class 1 drugs are sodium channel blockers. We break those down into 3 classes, the 1A, 1B, and 1C. You can see examples here for each, and that they actually have different effects on the action potential. So 1A are going to actually lengthen your action potential, 1B are going to shorten your action potential, and 1C have a variable effect on the action potential, whether they widen it or not. The class 2 agents are your beta blockers. Those are actually going to act here in phase 4, so your pacemaker potential. Class 3 agents are your potassium channel blockers. So we said the potassium current flows essentially from phase 1 on. So you can see they act across a very broad duration of the action potential. And in doing so, they prolong the action potential and will prolong the refractory period. Calcium channel blockers are going to act on the phase 2, which is dependent on calcium current. So these are interesting in that they actually impair impulse propagation, particularly in nodal and damaged areas relative to other areas of the heart. So I talked a little bit about the effects that these will have on the action potential. This is just showing diagrammatically, if you have a 1B, so something like lidocaine or mexiletine, these are pure sodium channel blockers. They don't affect any other channels. You can see the white would be your normal action potential. The yellow is with the 1B agent in effect, and it's actually going to shorten the action potential, so less width here. The 1A class, while we classify all of the class 1 agents as sodium channel blockers, 1A and 1C also have potassium effects. So 1A is a mixed sodium and potassium effect. It's going to cause a delay in your upstroke and a widening of your action potential. And then the 1C, these are our strongest sodium channel blockers. They're predominantly a sodium channel blocker, but they have a small potassium channel blocking effect. They will again slow your upstroke, so you get more of a delay here. And then they have a variable effect on whether the action potential width is different than baseline. With your class 3 agents, remember these are potassium channel blockers, although some of them do have mixed effects, such as amiodarone. Because they're affecting that plateau primarily, you're going to actually see widening of the action potential. We said that potassium currents run through basically everything after this upstroke, and so by blocking that current, we actually prolong our action potential. In addition to these effects, both the class 2 and class 4 agents, so our beta blockers and calcium channel blockers, also have negative chronotropy, negative dromotropy, and negative inotropy effects. So those last couple of slides are all things that you would have talked about and thought about in pharmacology class. In electrophysiology, we also like to think more anatomically and, of course, electrophysiologically in terms of the actual circuit components. So is this a circuit that involves the atrioventricular node? I just said some of these agents are particularly effective on nodal tissue. Is there a pathway involved? What is the pathophysiology of the circuit? So if we think about the circuits that we see in electrophysiology, in circuits that involve an accessory pathway, atrial tissue and ventricular tissue without involvement of the AV nodal tissue, we're thinking about things like class 1 drugs, procainamide, flecainide, propafenone, the class 3 potassium channel blockers, plus or minus some sympathetic stimulation. Once we invoke the AV nodal tissue, now we're thinking more about calcium channel blockers, beta blockers, acetylcholinergic kind of vagatonic maneuvers, so things that would be specifically targeted to the nodal tissue. And again, this is something that you'll probably hear more about in some of the more clinically oriented lectures, but just to remind you the pathophysiology in general of tachyarrhythmias. So we can think about tachyarrhythmias as falling into one of 3 buckets. The first would be automaticity. Automaticity, unfortunately, is not reliably suppressed by any of the classes of antiarrhythmics. There's triggered activity, which we can have both delayed after depolarizations, which are catecholamine dependent, and early after depolarizations, which are pause dependent. For the delayed after depolarizations, beta blockers may be beneficial, but in general, the goal here is to remove the cause driving these catechol-dependent processes. For the early after depolarizations, overdrive pacing is really the treatment of choice. Note that this can be either electrical, so with a temporary wire, or chemical with a drug like isoproterenol. And then there's reentry. So reentry has 3 basic requirements. You need to have an area of unidirectional block. So you have a circuit that comes down, and it theoretically could Y, so it could go 2 directions, and on one of those directions, there's unidirectional block, so the circuit can't go that way. That set you up to go the other direction naturally. And then you need an area of slow conduction. That area of slow conduction is going to give the tissue behind you time to recover, so that when the circuit comes around, instead of hitting block, it's able to repeat and just go around and around this circuit created by that essentially Y. Now, we see this in normal patients with dual AV node physiology. We see it in patients who have bypass tracts, which gives them the AV node and the bypass tract as the 2 pathways. And then in patients who have ventricular cardiomyopathies, scar in the ventricle often sets people up for multiple circuits. So a lot of the ventricular tachyarrhythmias in these patients are actually reentry within the scar. There are some clinical factors that should always be factored in or considered when thinking about antiarrhythmics specific to the patient. So things like renal and hepatic function, particularly renal function. So a number of these drugs are actually renally cleared. Sotalol, dofetilide, procainamide, quinidine, flecainide, and propafenone all can require renally dose adjustment, monitoring, or may actually be contraindicated depending on the renal function. Age and comorbidities significantly influence how you see and think about the toxicity of some of these agents, particularly amiodarone, and whether it can be used as a first-line agent or should be a later-line agent. Structural heart disease, so the class 1A, 1C, and class 3 drugs, with the exception of amiodarone and sotalol, should be avoided in patients with structural heart disease. Similarly, with left ventricular hypertrophy, class 1A, class 1C, and class 3 drugs, this time with the exception of amio, dronedarone, disopyramide, and sotalol, should be avoided. Pregnancy should be considered in any drug decision for patients. There are device issues. This is less important now with improvements in device technology, but in patients who have elevated defibrillator thresholds, you should consider that sotalol will actually lower or improve their DFT, whereas amiodarone can actually increase or worsen their threshold for defibrillation. And then it's worth noting that the congenital heart disease population, unfortunately, is just a challenging population in that none of these drugs actually seem to work particularly well in them. So when you look at data for performance of these drugs, keep in mind that it likely is not pertinent to how well they will perform in patients with congenital heart disease. So just a clinical example, a patient who comes to the ER with this electrocardiogram and is hemodynamically stable, you can see that the morphology of the EKG is varying beat to beat, as well both the width and kind of the shape of these complexes. And it is, in somewhat technical speak, a rather scary looking EKG. And you might make a prediction from this EKG about what the baseline EKG is going to show. And so this baseline EKG, as we might predict, does show a delta wave. So we have a short PR interval and slurring of the upstroke of our QRS complex visible in a number of these leads. So in a patient who has a bypass tract and is presenting with a wide complex tachycardia, which of the following would be an appropriate acute treatment in the emergency room? Procainamide, beta blocker, calcium channel blocker, or adenosine? So in this case, given the presence of the bypass tract, procainamide would be the treatment of choice. The concern is that this is atrial fibrillation conducting down the bypass tract. In that setting, we avoid nodal agents because they can actually cause increasing ventricular rates due to the loss of the rate-controlling properties of the AV node if we block it chemically. So procainamide is actually the historic treatment of choice in this clinical setting. So procainamide is one of the class A agents. It really is only talked about these days in the setting of AFib and WPW and rare patients requiring multiple therapies to suppress their ventricular tachycardia. But again, these class 1A agents are sodium channel blockers. They also do have some effect on the outward rectifying potassium current. So they're going to slow conduction and increase your refractoriness. As we talked about before, they'll actually widen the action potential duration. They also lengthen the QTC. And they are effective or active in both the atrium and the ventricle. So of the 1A agents, procainamide is the one that is most commonly talked about. The two other agents in this class are quinidine, which has a historical role in atrial fibrillation. It's really poorly tolerated in up to half of patients, and these days is really only used in refractory VT in a multi-drug regimen. And then disopyramide, which has negative inotropic effects and is really rarely seen except in two populations. One would be those with vagally mediated atrial fibrillation, and the other is patients with hypertrophic cardiomyopathy. So if we have a patient transferred from an outside hospital with this wide complex tachycardia, in comparison to that last wide complex tachycardia, you can see that this one is pretty stereotyped with the exception of this little burst where you see pacing spikes. So this is a wide complex tachycardia in a patient who has a defibrillator in place, and they're getting antitachycardia pacing appropriately for this ventricular tachycardia. So in a patient with VT like this, one of the drugs that we might use would be lidocaine, which is kind of our exemplar of class 1B. As we talked about before, the 1B agents are sodium channel blockers. They only affect sodium channels. They don't have any other effects. They actually shorten the action potential duration and selectively will affect conduction in ischemic cells more than non-ischemic cells, which makes them attractive in patients with acute ventricular arrhythmias. So in patients with acute ventricular arrhythmias, they're given as an IV infusion. They have a high first-pass metabolism and a relatively short half-life. They are hepatically cleared, and that should be kept in mind when considering dosing in a patient. The side effects are mainly central nervous system, so patients become drowsy, disoriented. They can have convulsions and hypotension when their levels become too high. And so we do, in general, follow levels in these patients to try and minimize toxicity, although you should monitor for clinical signs as well as the level. Don't be reassured by a normal level or kind of typical level in a patient who's having clinical signs. Their very short half-life is attractive for EP procedures because we can literally keep the drug on until shortly before we bring the patient downstairs. There is another agent in this class, mexiletine, which people think of kind of as an oral lidocaine. It should not be used with lidocaine. You should always switch from one drug to the other. You will get an increased risk of CNS toxicity if you use both together. Mexiletine is rarely used alone. It's generally an adjunct to another agent, and it should always be given with food in order to improve the likelihood that the patient will be able to tolerate it. The class 1C agents, the two most commonly used are flecainide and propafenone. As I said before, these are our most potent sodium channel blockers. They will increase the PR interval and the QRS interval in a dose-related fashion. If you see an increase in your QRS duration of over 20%, that's an indication to reduce the dose. Because these drugs slow conduction, they can actually cause a paradoxical increase in rates by transitioning you from a 2-to-1 conduction to 1-to-1 conduction. And so a nodal agent should always be given with class 1C agents in order to protect from that paradoxical increase in rates. These are also the drugs that are used for what are so-called pill-in-pocket regimens, which we're going to talk about in a minute. So the toxicity of these agents is use-dependent. That basically means that the effect of the drug increases as the heart rate increases. And so in order to see the maximal effect of the drug, we generally will perform a stress test once the drug has kind of been loaded and assess on that if we see that greater than 20% increase in QRS interval, which would cause us to reduce the dose. So you don't just assess on a resting EKG, but should also do it at maximal heart rate on a stress test. These agents, unfortunately, have been demonstrated to be pro-arrhythmic in the CAST trial. So the CAST trial was looking at patients who had had myocardial infarction and trying to suppress ventricular ectopy. And unfortunately, what that trial demonstrated was when these drugs were used, you actually caused VF arrest in this population. The thinking is that the slow conduction caused by these agents probably facilitates some reentrant circuits that converts ectopic beats to sustained arrhythmias, as well as the prolongation of the action potential duration causing triggered activity. So these drugs are contraindicated in any patient with coronary disease based on the observations in the CAST trial. I mentioned pill-in-pocket. So pill-in-pocket is a strategy that can be used in patients who have recent onset, so less than 48 hours of an atrial arrhythmia that's hemodynamically stable with a rate over 70. In the paper, there were lots of exclusions, so don't assume that just because the patient meets that first bullet that they would have qualified for the index trial on this. The dosing used for pill-in-a-pocket is 300 milligrams of flecainide or 600 milligrams of propafenone, and in the trial, patients were actually monitored for 8 hours following drug for the first administration. So this is just a flow diagram of the treatment and outcomes in these patients. Pill-in-pocket was effective in 84% of the outpatient episodes. 7% of the patients did have adverse effects, including rapid ventricular rates, as well as non-cardiac side effects. And the average time to resolution of symptoms was about 2 hours. So with pill-in-a-pocket, if the patient has tolerated this well in the hospital, in the emergency room, then this is something that you can instruct the patient to do at home for future episodes so they don't have to present to care. They just take out the pill that you've given them to keep in their pocket and take it as directed. Moving on to the potassium channel blockers, so class 3 agents. Potassium channel blockers are the class where we see the biggest risk of QTC prolongation, and as a result, the biggest risk of torsades de pointes. There are several drugs in this class worth talking about. Ibutylide is only available in an IV formulation and is not something that is used in an ambulatory setting in general. Dronedarone, which is the newest antiarrhythmic, we'll talk a little bit more about dronedarone in a minute, but going through some of the older agents, dofetilide and sotalol are somewhat similar agents in that they both are drugs where we really say that the patient has to be admitted to the hospital for inpatient monitoring when we're loading the drug because of this risk of torsades de pointes. With dofetilide, if you see a QTC increase of 15% above baseline or greater than 500 or greater than 550 in patients who have a bundle branch block, then you really should reduce the dose of dofetilide and continue monitoring. Sotalol is interesting in that it's a relatively weak beta blocker. It has reverse use dependence. So remember I said with the class 1C agents, they have use dependence. Their efficacy increases with increasing heart rate. Sotalol is the opposite. Sotalol is actually more effective at slower heart rates. What that generally means is that sotalol is very unlikely to chemically cardiovert a patient who's having an atrial tachyarrhythmia. The rhythm is going too fast for the sotalol to be effective. So in general, with sotalol loads, you'll bring the patient in, you'll give them sotalol for several days, and then you'll electrically cardiovert them. The drug can do a fine job of keeping them in sinus once sinus has been achieved. It's not good at getting them into sinus. That's in contrast to dofetilide, where a fair number of the time when you're doing a dofetilide load, the patient will actually chemically cardiovert before you get to your planned electrical cardioversion. Sotalol is preferred over dofetilide in patients with structural heart disease. Beyond that consideration, the use of these is often based on the relative comfort level of the physician using them. And then amiodarone. While we think about torsades as being the risk of the class 3 agents due to the prolonged QTC, and amiodarone certainly can prolong the QT, it is rarely associated with torsades. That doesn't mean it's never associated with torsades. But unlike dofetilol and sotalol and dofetilide, amio is a drug that you can load on an outpatient basis because it is low risk for being arrhythmogenic. So I've talked a lot about this QT prolongation. This is just an example of an EKG from a patient who was undergoing a dofetilide load as an inpatient. You can see that the QTC in this tracing is rather long, and if we compare that to their baseline, you can see that the baseline QTC is much shorter. So this is kind of your classic example of drug-induced QT prolongation. As I said, for both sotalol and dofetilide, we do require inpatient monitoring, generally observing patients for a total of 6 doses. The monitoring includes electrocardiograms that should be checked 2 hours after each dose, so trying to get kind of the maximal effect of the drug after each dose. In general, you should use the same lead consistently as you're assessing the QTC from EKG to EKG in a given patient. Leads 2, V5, and V6 are very often good choices for this. In general, you want a lead that has a good T wave, so one that's well defined and over 2 millimeters. And you want to, in general, measure the worst case, so look for the longest QTC on the EKG. This, of course, can be very challenging in patients who are having atrial tachyarrhythmias, particularly AFib. In general, you don't want to include the U wave for a QTC increase of greater than 15% or greater than 500, or again, greater than 550 in patients with a beta bundle branch block. You would dose reduce dofetilide. For sotalol, for a QTC over 520 milliseconds, you should not increase the dose. So amiodarone rates some discussion kind of all on its own. It is a drug that, while it's considered class 3 or a potassium channel blocker, it actually affects everything. So it is a sodium channel blocker, a calcium channel blocker, and a beta blocker, as well as a potassium channel blocker. The major acute effect is actually depression of the AV node. That means that the major acute effect of amiodarone is actually rate control, not rhythm control. And it is worth noting that amio has never been FDA approved for the management of acute atrial fibrillation. It has a very large volume of distribution with a half-life of about 55 days. So this is kind of the opposite of Lido. I said that Lido we can turn off and it's gone very quickly. Amiodarone will take weeks to months to wash out of a patient once they've been loaded. It is hepatically metabolized, and it has a broad range of toxicities. So this is only a partial list. Some of the toxicities we can see with amio include dermatologic problems, which can be both photosensitivity rashes and some gray or blue discoloration of the skin, thyroid issues, which we see in around 2% of patients, pulmonary fibrosis. In general, you do want to assess pulmonary function testing in patients before kind of consigning them to a course of amiodarone given this risk. Corneal deposits, central nervous system disturbances, gastrointestinal disturbances, can be proarrhythmic. It can cause heart block. It can cause nightmares in up to 25% of the population. Abnormal liver function tests in about 20%, although not all of those patients would require that the drug would be stopped. And there are a number of drug interactions. So amio has a lot of downsides to it, and that might make you ask, well, why is it that we're using it then? And the reason that we use it is that it works really well. So of the antiarrhythmics for atrial fibrillation, amiodarone is the most effective drug at maintaining patients without a recurrence of arrhythmias, doing much better than both propafenone and sotalol, as you can see in this example. Unfortunately, because of all the toxicity, while amio works very well, it is a drug that we're really reluctant to subject patients to long-term, particularly younger, healthier patients. So you'll recall I said that in patients who are older and have a number of comorbidities, that may be a consideration in having you use amiodarone on the sooner side as opposed to holding off and using one of the less effective but less toxic agents as a first-line agent. I talked a lot about dose adjustments for dofetilide in particular, and how much does that really matter? Well, unfortunately, it matters a fair amount. So this is the probability of remaining in sinus rhythm as a function of dofetilide dose. And you can see that dofetilide is much more effective at 500 milligrams than it is at 500 micrograms than it is at 125 micrograms. Note that 125 is still better than placebo, but the efficacy is very much dose dependent of these drugs, as demonstrated here. Now, I said that we were going to talk a little about dronedarone. So dronedarone, as I said, is the newest antiarrhythmic agent. The goal with dronedarone was really, is there some way that we can get all of the benefits, all of that wonderful antiarrhythmic effect of amiodarone and avoid all of that unfortunate toxicity? And the way that they tried to achieve that was essentially to remove the iodine moiety from amiodarone. And from kind of a patch clamp electrophysiologic standpoint, this does seem to have the similar acute electrophysiologic effects to amiodarone, which was very promising in early studies of this drug. As you might expect, it has also similar adverse cardiac effects to amiodarone. So it also causes bradycardia, it also causes QT prolongation. It is subject to CYP3A4 metabolism, and so there are some drug interactions that have to be considered. Both verapamil and diltiazem should be started at low doses when used with dronedarone, given their ability to potentiate dronadarone's effects. And dronedarone will increase digoxin levels by about 2 to 3-fold. So the trial experience with dronedarone, the Athena trial was a very promising trial. It was looking at patients with non-permanent atrial fibrillation and risk factors and actually demonstrated a decrease in cardiovascular hospitalizations, which caused a lot of excitement about the potential for this new drug. Unfortunately, that was followed by two less rosy trials. So Andromeda enrolled patients with class 2 to 4 recently decompensated heart failure. And that trial actually was prematurely terminated because they saw evidence of increased mortality in patients with heart failure who were taking dronedarone. And that was believed to reflect worsening heart failure. And then in the PALACE trial looked at patients with permanent AFib, And again, the trial had to be prematurely stopped because there was a doubling of mortality, stroke, and heart failure in patients randomized to dronedarone. So when the FDA approved dronedarone, it was based on that observation that it could reduce the risk of cardiovascular hospitalizations in patients with atrial fibrillation. The labeling was limited to patients with paroxysmal or persistent, so permanent was not included in the indication. And patients had to have associated cardiovascular risk factors. Again, to emphasize this, the third bullet, who are in sinus rhythm or who will be cardioverted. So the goal of this drug was very much focused on rhythm control. Given the observation of mortality in patients with permanent AFib, it's not a drug that should be used for rate control, although it does have rate controlling effects. When it was first released, the drug did have a boxed warning on it, mentioning class 4 heart failure or symptomatic heart failure with a recent decompensation as being contraindications to the drug. Once the drug was actually used, following its release, there were some post-marketing reports of heart failure that prompted further labeling changes regarding risks around the drug's use in new or worsened heart failure. There have been rare cases of torsades reported with dronedarone, so similar to amiodarone, rare but not without this risk. Drug interactions were reported with dabigatran and warfarin. There were unfortunately rare cases of fulminant liver toxicity, including cases necessitating liver transplant. So monitoring of liver function tests is now recommended with this drug. And pulmonary toxicity was also observed. So a lot of the toxicities that they had hoped to avoid were not fully avoided, and the drug has not exactly flourished in terms of its use. So taking a moment just to kind of think through a case, a 75-year-old man with prior MI and severe renal dysfunction, so a creatinine clearance less than 30, who comes in with atrial fibrillation and a ventricular rate around 110. Which of the following is an appropriate agent for rhythm control? Flecainide, sotalol, dofetilide, or amiodarone? So in this patient, given the degree of renal insufficiency, we would not use either sotalol or dofetilide. And the class 1C agents, as we said before, are contraindicated in patients with coronary disease, including patients with a history of CABG. While amiodarone does have some substantial toxicity, it is a very reasonable first-line agent in a patient like this. Again, keep in mind, patients who have more comorbidities, we do tend to think that amio is reasonable. Most of the toxicities with amiodarone are relatively long-term and likely would not be a significant concern clinically in this patient. So we've talked a lot about drugs that electrophysiologists use a lot of the time, but almost no one else ever touches or uses. We're going to change gears here a minute and talk a little bit about drugs that hopefully everyone is comfortable with. So the class 2 agents and the class 4 agents are beta blockers and calcium channel blockers. It's important to keep in mind that both of these classes, in addition to being nodal agents, so drugs that will slow conduction in the AV node, both of these are negative inotropes. And so in patients with decompensated heart failure, the negative inotropic effects of these drugs can be substantial and can significantly impact clinical course. So use them with caution in patients with decompensated heart failure. There are specific arrhythmias that can be exquisitely sensitive to these drugs. So for example, Bellhausen's vesicular ventricular tachycardia is exquisitely sensitive to calcium channel blockers. An important drug that bears mention that is not included in the von Williams classification is adenosine. So adenosine is a purine nucleotide that activates adenosine receptors. It will slow AV conduction, and it's used as an acute therapy for nodal dependent rhythms. It can cause termination of SVT, and it can allow you to diagnose VT. It's given only IV as a rapid bolus, and its half-life is less than 2 seconds. Patients do not tend to like this drug, so it can give them a feeling of impending doom. It can cause flushing, dyspnea, chest pain, transient arrhythmias, and it's contraindicated in patients with asthma or heart block. but it is an important drug to keep in mind, and a drug that, like beta blockers and calcium channel blockers, is used widely throughout internal medicine rather than just by EPs. So in summary, the antiarrhythmic drug selection depends in large part on the rhythm one is attempting to suppress, but also needs to take into account patient factors such as renal function and comorbidities. Antiarrhythmic therapies can be proarrhythmic, particularly in at-risk populations. It's important to think about those at-risk populations as you're making your drug selection and making your plan for monitoring the patient, as appropriate monitoring and associated drug adjustment is key to minimizing the risk of proarrhythmia. And these are some references that can provide additional information on antiarrhythmic therapies.